laryngoscopy. And if you've accomplished the goal, only then do you move on to the next step. So the first step, proper positioning, and our goal is to have this hole on the same line as this hole. We've accomplished that. We can now move on to the next step. And the next step of laryngoscopy is to open the mouth. And if you don't open the mouth wide enough to translate your mandibular processes, you can't dislocate the jaw when you try to intubate the patient. On yourself, what you do is push your fingers 1 centimeter forward and 1 centimeter down from your auditory meatus, and then slowly open your mouth. And what you'll feel is your actual mandible pop out against your fingers. Until that point, you cannot intubate this patient very easily. So, what you want to do is on your patient, open the mouth wide enough for that to happen. And you don't actually have to feel, you just open the mouth as wide as possible, and you'll be able to dislocate that jaw when the time comes. If you don't open the mouth very much, if you just put your blade in like this, there's a good chance you'll not be able to successfully intubate the patient. Especially for trauma patients where their head's not tilted back, and therefore the jaw's not opening automatically. For those folks, very difficult to intubate unless you get a nice big mouth opening with scissor technique. So that's your first cognitive step, and you know you've accomplished it when the mouth is open. Alright, your next cognitive step is you grab your laryngoscope, and you just put it in the mouth. Now on this guy, it's easy for me to put 1 inch of the blade in the mouth. And that, if you've done that, you've accomplished the next step. But some folks, because they'll have a big chest or they're pregnant, you won't be able to get this blade in the mouth. You'll try to get it in, it's not going to work. What you'll do in that case is just drop it in 1 inch horizontally and then turn. And now you accomplish the next step of laryngoscopy, which is to have 1 inch of blade in the mouth. If we've accomplished that, we can move on. Next step is to hold your laryngoscope blade very lightly, and you go dead center down the tongue. And you're just going to inch down the tongue ever so slowly until you see a sliver of epiglottis. And we'll show you a screenshot of that, what that looks like. But right now I'm looking at a sliver of epiglottis at the base of this tongue. See a sliver of epiglottis. I'm not lifting at all. You can see I'm putting no pressure really on this blade whatsoever. I've just inched my way down the tongue until I saw a sliver of epiglottis. And now I stop because I've completed a cognitive step. I'm ready to move on. At this point, this hand goes to the thyroid cartilage. And what you're seeking to do now is take the potential space of the vallecula, which I see right now, and turn it into an actual space. And the way that happens is by pushing down on your thyroid cartilage. And so you take this potential space and you make it a big actual space. And now I have a huge vallecula. So the next step is to make the vallecula an actual space and slide your blade into it. Alright, my blade is now lodged in the vallecula. This is the first time I'm actually going to be applying much pressure at all to the laryngoscope blade. And what I'll do now is at the same time I'm lifting up with the blade, I'm pushing down with my fingers on the thyroid cartilage. So I'm doing bimanual laryngoscopy. And what I'm looking for is the posterior notch. That's my next landmark. When I see the posterior notch, I know I've identified the cords. And now I'll stop, and in my mind I'll say, I've now identified the posterior notch. If you're not finding it, don't go on, because that's how you wind up in the esophagus. So you're going to keep lifting until you see the posterior notch, which is the most posterior structure of the airway. Once you see the notch, now you're going to optimize your view. And that just means more burp, more external laryngeal manipulation, maybe a little more lifting, until you have a great view of the cords. That's your next step. Have enough view of the cords so you can pass a tube. If you only still have that posterior notch, grab a bougie. If you see the posterior notch, you'll be able to pass the bougie. And the last step of this is now going to be to pass the tube. So now we're ready to actually pass our tube. And we have our tube set up what we call straight to cuff, which means it's totally straight until the cuff, and then we put a 35-degree bend on. Now, on a real patient, it should be at least an 8/0 tube, unless there's some compelling reason not to use an 8/0. It makes pulmonary toilet a lot easier. Now, here's the mistake people make. They see their cords, they're all excited, and they get in there, and they're ready to pass the tube like this. That will cut your view entirely of the laryngeal orifice. What you want to do instead is you turn it horizontally like this, and you come, your eyes are totally on the cords, and you're coming in from the side horizontally. You're not going to see anything to obstruct your view until the tube is directly in front of the cords, and then you can actually see the tube pass through. So again, the motion is horizontal, 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 and only at the last second do I tilt it in and turn. What this allows you to do is, since you're coming in horizontally, look at this. I could go up, 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 up for an anterior larynx. Oh, I can go down, down, down for a posterior. I have full control with just the tiniest movement of my fingers. I don't have to do any great big motions like this, pushing up against the back of the patient's throat to try to move it in. So you come in horizontally, and only at the last second do you tilt the tube in. Same thing with the bougie. That's the motion. Horizontal, horizontal, horizontal. Tilt until you're just in front of the cords. You see the tip at the cords, and then only at the last second you go forward. Now sometimes you'll get to that very last bit, and you'll have the tip of the tube through the cords, and you can't advance. Just have your friend pop the stylet out about a centimeter, and then you'll be able to advance.